My name is Peter van der Kerkhof, and I'm so glad here to be together with Professor Mann. My profession actually is dermatologist. I'm senior professor of dermatology at the Radboud University Nijmegen Medical Center. That is a place in the Netherlands. And internationally, I have given a lot of lectures, but also a lot of publications and work with colleagues internationally in the field of psoriasis. And in this way, I have been a few times in China. I like that very much. It was really great to see also the great work that the Chinese colleagues are doing. And I'm so glad now to be with Professor Mann.
Thank you, Professor Peter. It's so great to see you in America and also during AAD. Professor Peter also go to China many times and also help us in psoriasis, and also I think that in China that dermatologists are very familiar with you because for our dermatologists in China that we do research, the clinical and the basic researches on psoriasis. Also we all want to join IPC. So I think that also during this process, Professor Peter gave us many help. My name is Xiaoyong. I'm from China, from Zhejiang University, the second elephant hospital. And also, just like Professor Peter, I'm also a dermatologist. My major is focusing on clinical and basic research on psoriasis. Also, it's so good again to meet Professor Peter here.
So good again also to see you again. I think we could start actually by speaking a little bit together about early diagnosis and early intervention with psoriasis.
Yeah, indeed it is very important for early diagnosis of psoriasis. Although you know that someone may think that diagnosis of psoriasis is easy. In fact, there's still many patients that they are misdiagnosed as some other disease because it is a very early stage.
Yes.
Some patients, they have atypical presentation, so we must check. Sometimes we check by using dermatoscopy and also do skin biopsy to confirm the diagnosis of psoriasis.
Yes.
And also, as you know, that for the delayed diagnosis of psoriasis may also delay the treatment and then delay the diagnosis of the comorbidities of psoriasis. For example, for psoriatic arthritis, in some patients, indeed, they progress from psoriasis to psoriatic disease to psoriatic arthritis.
Yes.
Maybe this is, especially in some patients that for the psoriasis signs is not so obvious. Sometimes, for example, for scalp psoriasis, if the patient have arthritis, they go to see rheumatologist, not to come to dermatology. So there's some delayed diagnosis of psoriasis.
Yeah, the delayed diagnosis of psoriasis and delayed onset of the treatment will make it more difficult actually to treat psoriasis in an effective way. For there is a window of opportunity when psoriasis is only there for a few weeks or a few months. Then in that situation the treatment can be easier. And for the diagnosis, of course, we have to look to the clinical aspects in classical dermatology. And that is, of course, the sharply demarcated erythematosquamous plaques on the predilection sites, the elbows and the knees. And all dermatologists will diagnose that quite easily. That is easy. And also many GPs won't have a problem with that. Sharply demarcated erythematosquamous plaques is nearly in all cases is that chronic plaque psoriasis. But especially in children, and when psoriasis is only there for a few weeks, it can be a little bit more difficult. It could be that you'll only have some scaling on the scalp, and maybe also a furrow in the intergluteal area. So in the sacral region to have only a small furrow, which is somewhat painful. And then, of course, looking in the groins and in big flexures, you may see some erythematous lesions. And when you see not the classical psoriasis plaque, it can be sometimes somewhat difficult to have the right diagnosis.
Yes.
And then you mentioned dermatoscopy. That
Yeah.
is interesting. And where do you look at with dermatoscopy? What is important? What is the picture, what you would say to your colleagues, is the classical picture during dermatoscopy for the diagnosis of psoriasis? What is
Yes,
it?
this is very important, that for dermatoscopy that we can look at some the vessels, dilated
Yes,
vessels,
dilated.
that it's very regular, and also we can see that it is some dotted. I think it's the red dot, and also it's a very regular red dot.
Yeah,
And
like you
also
can
for
see
a-
sometimes on the lunula, in the nail, red spot of lunula.
Yes.
And in that way you also have red dots when you look with dermatoscopy. When you would take histology, that would be the site of the squirting papilla, I think, where the endothelium is there, where neutrophils are invading in the skin, and you can have accumulation of neutrophils, which
Yes.
the dermatopathologists feel as very important diagnostically. But so you have the opportunity with your dermatoscope not only to look at pigment nivae, but also for the early diagnosis of psoriasis.
Yes, although sometimes that we even that have a histology, but that sometimes it's, as you said, that it's not so typical.
Yes.
So maybe the histology also cannot give you very accurate diagnosis of psoriasis. But as you mentioned about this, for the infiltration of neutrophils and for the mural abscess is a very typical one.
It's a very typical one, but you
Yeah.
are right, it's not so frequent. When you have
Yes.
a chronic plaque lesion and you take a biopsy, then the micropustules of Kogai, so the accumulation of neutrophils, is actually difficult to find.
Yes.
You have a good chance that the pathologist doesn't see it and may say, yeah, I see thickening of the epidermis, acanthosis, I see some parakeratosis, for me this looks like chronic eczema.
Yeah, it's actually like the dermatopathologist that is acanthosis, and also for the epidermal retige, elongated epidermal retige is a typical psoriasis form dermatitis.
Yes.
Yeah.
And I think it's important, when you take a biopsy for the diagnosis of psoriasis, then it's important to ask the patient, is this a chronic lesion or is this a lesion which has expanded?
Yeah.
And you have to look to expanding lesions and then take the biopsy from the margin, not from the center.
Yes.
For there you have the highest chance to find the classical morphology of psoriasis. But you may miss with the histopathology actually a classical clinical diagnosis of psoriasis, just for the reason that there are no neutrophils anymore.
Yeah.
And that's nice with dermatoscopy. You overview a whole picture and then you see the red spots, and that is fantastic.
Yeah, that is, so it's a very, just like the classical of the psoriasis in dermatoscopy.
So-
Sometimes we don't use the histology, that we can also no problem. It's psoriasis diagnosed by the dermatoscopy. Yeah.
So early diagnosis, very important for psoriasis, and I think also the early detection of possibly comorbidities.
Yes.
That is, for me, when I see a patient for psoriasis, with psoriasis for the first time, mostly the patient has no psoriatic arthritis. And during time, 30% of the patients develop at some time psoriatic arthritis. And that can be every year. Every year that you see the patient can develop psoriatic arthritis. But for early diagnosis here of psoriatic arthritis, I think it makes sense to be as early as possible with the treatment to prevent damage of the fully developed psoriasis lesion. And myself, I often look at the nail, when there is true nail psoriasis, then there is an increased chance that a patient may develop psoriatic arthritis. Also in very extensive psoriasis, all over the body, there is an increased chance, but we have to be alert. And we have also to ask actively to the patients, what is your view on the role of the dermatologist here in the diagnosis of psoriatic arthritis?
Yes, in China, with dermatologists, we not only ask the history of the patient about if there are any pain, any swelling of the joint, and also we ask the patient the duration And also we check about if the patient have nail psoriasis and also scalp psoriasis. Also, because that for scalp psoriasis and nail psoriasis is risk factors for psoriatic arthritis. And sometimes we use ultrasound. We use ultrasound to check if there are any damage or any swollen of the soft tissues.
Yes.
And also we may have some laboratory examination for the routine blood count and also for the CRP, C-reactin protein, and also for the ESR. And what they do check if the patients have the psoriatic arthritis. Because that according to the diagnosis criteria or classification criteria from GRAPPA, that we can classify the patients as psoriatic arthritis or not psoriatic arthritis or some other, because we have to have some differential diagnosis with some other arthritis patients.
Yes.
Yeah.
But dermatologists have an important role there, I guess, for usually, so I start with the skin. And then later on, and we should be very active, I think, in finding out. The other thing is cardiovascular risk factors and cardiovascular comorbidity. In IPC, we did a study and found that already children with psoriasis are obese in general. And there is an association between obesity and psoriasis. And the question arises a little bit what the role of the dermatologist is with respect to the diagnosis of metabolic disease and cardiovascular risk factors. Do you think it's important that dermatologists screen their patients for cardiovascular risk factors?
I don't think that it's important because that for some patients, as you said, the patient have a metabolic and also some cardiovascular disease and also for obesity.
Yes.
Because this type of the patient may have a high risk for sometimes it's a very high lipid. The high lipid may cause the cardiovascular disease, and for this cardiovascular disease, some patients may have a risk to have some heart risk, some other heart disease. That is for the patient maybe different in their life. So I think maybe this is very important. But sometimes it's because we are dermatologists, maybe it's not so easy to diagnose the CVD, the cardiovascular disease. So we have to maybe have an MDT with the cardiologist.
I think so, yes. Good collaboration with the cardiologist is important here. But as a dermatologist, we see patients with psoriasis, we realize that it is not only the skin, we have to realize it's also the joints, and it is also, of course, the cardiovascular aspects. And then with respect to early treatment, I have been trained 40 years ago in dermatology, and we had actually some topical therapies, corticosteroids, ditranol, tar. We had then methotrexate and cyclosporin, and in those days we generally said we have to be calm with the treatment of psoriasis, just a step-up scheme and take it easy. Psoriasis is not at all a dangerous disease, and a little bit watchful waiting. But now we have a lot of new therapies, and these therapies are highly effective and also are fast. And now PASI 90, PASI 100 is an opportunity in many patients to reach that. And also the long-term control is much better. And also prevention of comorbidity is there.
It's a very good question. I think that because in China maybe different from Europe and different from America, because that for the biologics in China come to the market and also covered by the Chinese medical insurance in 2019. So it's late than Europe. It's about 15 years later because the first biologics were approved by FDA in 2004. It's very popular for severity. That severity is the first one that is covered by Chinese medical insurance, and also the price decreased at that time is very significant. So the patient can afford it, can get it. But before 2019, it's just acitretin, cyclosporin, and methotrexate, and the patient cannot get very good results, and also some side effects by these medicines. But now it's it's easy for Chinese psoriasis patients, they can get it. Because in China, for the medical insurance, they have one requirement that the patient must be moderate to severe psoriasis, and just the patient is moderate to severe psoriasis. But for severity of psoriasis in China also is different from Europe and from America, because in China for the severity of psoriasis is classified as mild, moderate, severe.
Yeah.
And the difference is that mild is less, for example, by using BSA, in China it's less than 3% is mild, but 3 to 10% is moderate, but more than 10% is severe. So the patients, even they have less than 10%, but they have much more than 3%. So the patient can cover it by the medical insurance. So this enlarges a large population of the psoriasis patients. Another is that that for the IPC also they have some special site, and also for some that patients they are effective for the topical creams. Also they can enter into or covered by the medical insurance. So in China, for psoriasis patients, that is they get the systemic treatment is not so difficult.
Yeah, that is 40 years ago. We treated most patients with topical treatments, and only a few patients got a systemic treatment.
Yeah.
And now we realize that psoriasis is a systemic disease, that there are comorbidities, and we also realize that patients are suffering very much from psoriasis of the skin. It is really, quality of life is impaired very much.
Yeah.
And new treatments have become available. So in the International Psoriasis Council, we then have said in disease severity, there are two categories. One category of patients are the patients who can be treated with topical treatments, and the other category should be treated with systemics. Now, which patients should be treated with systemics? Or it could be that the patient has a body surface area involvement of 10% or more, and that makes sense. For when there's more than 10%, then applying ointments takes too long. That no patient will do that longer than 1 or 2 days. And the other thing is that when BSA, body surface area involvement, is 10% or more, there's increased chance for comorbidity. Or it can be that the patient has psoriasis on high impact sites. What are high impact sites? The face, the scalp, the flexures, the genitalia, the palms and the soles and the nails. It is very important that when patient has an involvement of those sites, and also when the patient has only a body surface area involvement of only 3% or 1% even, but has these high impact sites involved, the dermatologist is able to prescribe a systemic therapy, including a biologic. And then it could be, and that's the third criteria, that the patient is not effectively responding to topical therapy. So the patient, according to our definition, is not responding to topical therapy when the patient has had 2 courses of 4 weeks with an adequate topical treatment. And if in that situation the patient cannot reach the treat to target, and that in most countries is that a PGA of 0.1 or a BSA less than 1. So we have to be quite ambitious here. And in those situations, you can prescribe a systemic. But then, we have the classical systemics now, and we have the biologics, and we have the small molecules. What are your preferences? How are you dealing with that?
I prefer biologics. Because I think that the patient don't need to take oral medicine every day, and also they just have some injections. But that some patients they are afraid, especially some girls, some young guys, they are afraid of the injection. They want to take some oral medicines. But that for the efficacy, then biologics is better than small molecule inhibitors.
I often ask patients when they come, firstly, about comorbidities. When there's a comorbidity, we have to treat also that comorbidity. And when there's psoriatic arthritis, it's nice to have a drug which is effective on the skin and the joints. For example, methotrexate or anti-TNF or an anti-IL-17 are effective on both. But it's important to know that whether the patient has psoriasis and also psoriatic arthritis.
Yes.
And then I usually ask, what about the comorbidity of cardiovascular disease and metabolic disease? And I look at the patient, and when the patient really has an overweight, but also when the patient has other risk factors, increased lipids, hypertension.
Yes.
I take especially care of that, not directly myself, but I do that together with the general practitioner and say, note this patient has psoriasis and there's also some risk factor for cardiovascular disease. So it's important that we prevent here cardiovascular disease.
Yes.
There are some indications that methotrexate, anti-TNFs and also the anti-IL-17s may also prevent the cardiovascular disease.
Yeah.
And then I ask a third question, and the third question is, are you in a hurry? When the patients really suffer badly and cannot live with their psoriasis, have a family life which is distorted by psoriasis, and really have to hide themselves, there is more urgency than in a situation where the patient is saying, well, I have psoriasis, but I would like, of course, that psoriasis now becomes a little somewhat better, but I'm not exactly in a hurry. Well, when the patient is not in a hurry, then usually I may start with methotrexate or give phototherapy maybe first, and then start with an anti-TNF. But when the patient is in a hurry, I always start with an anti-IL-17, anti-IL-23 immediately. And there can be medical indications also. When you see that a patient may develop erythroderma, that's a medical reason to be in a hurry. And then we cannot do the stepwise approach. How do you handle this?
You know that in my department, when the patient comes to see me, I will tell the patients the benefits and also some side effects about different kind of medicines. But in China, it's different. These drugs that the patient may take it not so regularly. They also have some other medicines, also traditional Chinese medicine, and also think that this cannot solve their problems. This is very important. If the patient can, by using their some medicine just like biologics, if the patient have a very good efficacy and also there are no obvious side effects and also it's very cheap, why not?
I think we have covered actually several aspects in clinical practice and also the great opportunity to work with this whole spectrum of treatments that I think that actually the future is bright for our patients with psoriasis, where we have to offer so many things, and it is important that patients come for the consultation and that we as dermatologists are ambitious and strive indeed as much as possible to clear skin.
Yeah.
Thank you so much.
Thank you so much.